السلام عليكم أعزائي طلبة المرحلة الرابعة. اليوم راح نتكلم عن المحاضرة الأولى، راح نشرحها بالصورة والصوت لأنه بعض الطلاب ما فاهمين المحاضرة أو بها بالنقاط الغامضة. مثل ما قلنا الإندوكراين سيستم أو endocrine gland involve many endocrine gland in our body, and the term endocrine in the physiology we have three terms. We have endocrine, we have paracrine, we have autocrine. The endocrine gland which secrete the hormones which act far away from the original gland. في حين الباراكراين produce hormones affect nearby tissue. في حين autocrine affect on the same gland. So the endocrine gland produce its hormone to the blood circulation, affecting the target tissue which are remote from the original gland. We have many axes in the endocrine gland. We have the hypothalamus, we have the pituitary, we have the endocrine gland اللي ممكن تشمل لك controlled by pituitary gland, which involve the thyroid and adrenal gland and gonads, and the gland is not controlled by thyroid gland, by pituitary gland. And these glands produce hormone which affect on the receptors or target tissue to produce its effect. These hormones level controlled by the balance, by the requirement and the over secretion to maintain the normal level of the hormones. You see in this diagram, you having the level of the hormones, which is the original or the target tissue hormones produced by the endocrine effect on target tissue. We have estrogen and androgen and prolactin. These hormones are gonadal hormone which affect by negative feedback on the gonadotropin releasing hormone, which is produced from the hypothalamus, which by the way affect on the pituitary gland to produce LH, and so on, affect the gonads by this hormone to produce more estrogen, with estrogen affect then the GnRH and so on. So the maintenance of this hormone level with the normal range maintained by the feedback mechanism. The same for thyroid gland, T3 the active form, which affect the TRH, thyrotropin releasing hormone from the hypothalamus, which affect on the TSH by thyroid hormone or pituitary gland, affect on pituitary gland to produce TSH, which then affect on thyroid gland to produce T4, TSH, and so on. So these hormones affecting the hypothalamic secretion of the original hormones by the negative feedback. But we have one of the hormones which having the reverse mechanism. When the hormone it is having more inhibitory. When the hormone decrease, it is more secretion, which is differ from the others. This is hormone is dopamine. When dopamine level increase, it will suppress, and when it decrease, it will increase or inhibit the level. When increase level of dopamine will inhibit the level, when decrease with increased secretion, reverse to other hormones, and so on. The pituitary gland having two lobes, anterior lobes and posterior lobes. Anterior lobe produce all these hormones, prolactin, growth hormone, ASTH, and TSH, and LH, FSH, while the posterior lobe producing two hormones, ADH, which is required to maintain the normal homeostasis for the homeostasis for the fluid electrolytes, for the sodium and potassium, and also oxytocin, which affect on the uterus and the breast for lactation and labor. Now we have other endocrine gland which not controlled by pituitary hormones, which are the thymus, the abdominal body, and the heart, producing some hormones, and pancreas, kidney, and parathyroid gland. These not controlled by pituitary gland, controlled by its own response to the target tissue level of hormones. Example, parathyroid gland producing PTH. This parathyroid maintain the normal level of serum calcium. When the serum calcium decrease, the PTH hormone will increase. When the serum calcium increase, the PTH level will decrease. So the target or the signal for the secretion of PTH will depend on the serum calcium. And also for the pancreas, which produce insulin. Insulin also, the signal for the insulin secretion هو hyperglycemia. When there is serum glucose level increase, stimulate insulin. When the serum glucose level decrease, inhibit insulin. So this is the signal for control, not controlled by pituitary gland like thyroid, like adrenal, like gonads. So this is the other endocrine. All these, we call it endocrine system. Now, the endocrine gland or endocrine disease, either we have oversecretion of the hormone or decreased hormone. And the oversecretion, either primary disease in the gland, we call it primary, or secondary, signaling from the other gland, we call secondary. Like hyperthyroidism. When the thyroid gland produce more hormone, we call it hyperthyroidism. If the thyroid gland produce T3T4 by its own, adenoma, hyperplasia, autoimmune disease, producing hormone, its own primary disease. When the cause of the hyperthyroidism from the pituitary gland, over secretion of TSH, stimulating the thyroid gland, causing secondary hyperthyroidism, and also for hypothyroidism, and so the disease either hormone excess or deficiency, between primary or secondary. And also we have hormone hypersensitivity. يعني there is oversensitivity of the hormone producing over response causing disease. The same or reverse the resistance. When there is hormone resistance, the tissue not respond to the hormones producing the disease or the tumor, which causing mass effect or causing defect or ischemia in the gland causing disease. So this is the endocrine disease, as simple as that possible. The principle of endocrine disease, when we expect endocrine disease, we should investigate. But the investigation in the endocrine disease differ from the usual disease. In case of renal disease, we send for renal polyuria, serum creatinine, serum potassium. We send for serum calcium randomly. But in case of thyroid, in case of hormone disease, we require timing of the measurement. Why? Because some hormones not secreted continuously in the whole day of the month. Example, serum cortisol level. Serum cortisol secretion mainly in the early morning. So the measurement is based in the early morning to assess the level of the serum cortisol, if it's increased or decreased, and we direct it to other investigation. Also for testosterone level, mainly in the early morning. Melatonin level. Melatonin, which is responsible for the sleep rhythm, is mainly at night. And also for testosterone in the early morning. Regarding gonadal hormone, اللي هو LH and FSH, which produce in the monthly variation, monthly cycle. So the measurement require perfect time from the menstrual cycle to measure the FSH, LH, and giving the perfect level of increase or decrease. Also for the other hormones. For example, PTH, also pulsatile, and require measurement special number. Now, after timing of measurement, we having choice of dynamic biochemical. When we expect there is decrease or increase or decrease, we require stimulation test, dynamic test. Example, in case of growth hormone, we cannot measure randomly. We require induction of growth hormone by many factors, either sleep rhythm, after 1 hour of sleep, or after hypoglycemia, we induce hypoglycemia, or drugs. So this is called dynamic test, then stimulation test, to assess the perfect level of the hormone if the gland involved is deficient or hyperplastic. Imaging also required for the investigation, which require imaging ultrasonography or CT scan or MRI to assess the gland, if there's adenoma or if there's hyperplasia, and so on, and biopsy if we have a lesion. So this is the principle of investigation for the thyroid hormone. And now we talk about the symptom. We have symptoms shared between the disease, manifestation shared in the some disease. Example, weight gain can be seen in case of hypothyroidism and Cushing's disease. Weight loss can be seen in DM, thyroid sclerosis, and adrenal disease. And sometimes coarse feature can be seen in acromegaly, hypothyroidism, and so on. So this is the sharing. So those patients with endocrine disease require careful history, careful examination, and investigation to assess which gland have been involved in its or in his illness. The first gland, which is the most serious one and most common one, was thyroid gland. Thyroid gland present in the neck, in toe lobe, and isthmus, but responsible for production of thyroid hormone by synthesis from the raw material tyrosine and iodide to producing T3, T4, which secretes the circulation as T4, and T3 is the active form, and T4 is the as growth hormone, which is the most abundant and which is have longer half-life. T3 have short half-life but more active. These hormone, the free one, which is more active one, about 1%. 99% is bound to the protein. You see the effect of this hormone involving many organs: cardiac, GIT, CNS, bone, cell differentiation. You see, if we have thyroid disease, so all these elements of the body, all these organs are affected. Like in case of hyperthyroidism, we have increased T3 and T4. So more beta agonist activation, causing tachycardia, causing GIT motility, increased diarrhea, causing apprehension and palpitation and anxiety, and bone affecting bone nodular, causing osteoporosis, and so on. So the thyroid gland is very important because the thyroid hormone affects whole body metabolism. Now, we discuss about the feedback mechanism, how we control the level of BTH and TSH and thyroid hormone by the demand and the oversecretion. And we have also the requirement of iodide daily, about 100 mg per day. In our society, in the south of Iraq, the iodide is abundant in our food, in the fish, in the vegetables, and the having good iodide supplement. So not require iodide supplement. But in north of Iraq, like mountains, they have loss of no source or less source of iodide in the food. So they require supplement of iodide, and the deficiency of iodide is common in that area. But in our society, in our governments, in our region, we have no iodide deficiency because most of our food contain iodide. Iodide required for synthesis, and as we talk, T3 is the active form, and T4 is the growth hormone or as a spare for T3. And we discuss the hyperthyroidism. Hyperthyroidism, when the gland secrete more T3, T4 more than normal, the body will respond to this hypersecretion, causing hyperthyroidism. The cause of this disease having multiple causes, but the most common, about 30%, we have Graves' disease, اللي هو autoimmune disease produced by antibody affecting the thyroid gland to produce more T3, act in the TSH. تجي هاي antibody تقعد على TSH receptor to produce more T3, T4. So autoimmune disease, Graves' disease, common 76%. Less common هو المونتي goiter, causing 14%. Less adenoma, and so on and so on. Thyroiditis, which is inflammation of the thyroid gland, which can occur after viral infection, we call it the Kervian, or after postpartum. You see this cause in the list of hyperthyroidism and also in the hypothyroidism. How this occur? Because in case of inflammation of the thyroid gland, in case of thyroiditis, we have early phase of secretion of thyroid hormone after inflammation and tenderness. Then, after the hormones have been finished or there is decrease in the thyroid gland, the patient enter the hypothyroid phase, and then after recovery will reach the euthyroid phase. من نقول ايو معناتها normal thyroid gland. من نقول hypothyroid أو hyperthyroid. This patient is euthyroid. This patient is hypothyroid. This patient is hyperthyroid. So this thyroiditis come with hyperthyroidism, then hypo, then euthyroid. So the thyroiditis can be seen in the list of hyperthyroidism and hypothyroidism. Other induced in case of a drug on their own, or a contrast media, or in case of factitious, or in case of tumor induced, and so on. Manifestation, common, less common. The common is very important, اللي هو weight loss, despite good appetite, heat intolerance, sweating, palpitation, tremor, which caused by beta agonist activity. And in the sign, we have weight loss, tremor, pulmonary edema, tachycardia, lead detraction, and lead lag. This sign, very important to know. This is lead detraction. When the upper sclera have been appeared. Normally, this sclera not apparent in the eye. When the sclera apparent, we call it lead detraction. Lead lag, this, when we move the finger, normally, after the active movement like this, we follow the finger. When the eye move, normally, the eyelid sticky on the cornea. No gap between the cornea and eyelid. In case of hyperthyroidism and in case of hyperstimulation of muscle, we call it related barrier muscle, اللي هي for eyelid movement. So activation of this muscle causing gap between the eye cornea and the eyelid. So this is what lead lag. So lead lag is the movement sign, and retraction is this sign. And also you have chemosis in case of Graves' disease, and we have periosteal hypertrophy causing clubbing-like picture, and hyperthyroidism edema. These signs seen in case of hyperthyroidism. Other lab finding can be seen in those patients. We have raised ALT, raised GGT, alkaline phosphatase also increased. There is raised bilirubin and raised hypercalcemia, glucosuria, and diabetes mellitus because antagonism of the T3T4 to the insulin action, and black storage glucosuria also have been seen. Postprandially, there is glucosuria seen in case of hyperthyroidism. Treatment of those patients we discuss in the next lecture. Depend on the age, depend on the condition, the diagnosis. It's either drugs, anti-thyroid drugs, or radioactive iodine, or surgery. Depend on the age and the diagnosis. Other support treatment were beta blocker, either propranolol or nadolol, which given in high dose, given to control the manifestation by two mechanisms. Number one, beta blocker antagonize of beta agonist, وبالتالي decrease the manifestation of tremor and palpitation. Number two, the beta blocker have been shown to decrease the conversion of T4 to T3 in the peripheral tissue. So less T3, which is more potent hormone, and less hyperthyroidism manifestation. So dual effect of beta blocker required or manifested in case of hyperthyroidism. AF is common, and about 10% of patients with hyperthyroidism having AF, mostly in the elderly, and thus require treatment of the underlying cause before the treatment of the AF by the drugs or by cardioversion, and so on and so on. This is the thyroid stone, which is rare, but high mortality, about 10%, occur in case of poorly controlled or undiagnosed patient hyperthyroidism, or patient having hyperthyroidism going to stress, either infection or surgery. Patient having hyperthyroidism, having high T3T4, and having low and suppressed TSH. So those patients require treatment with anti-thyroid to control the level of hormone and suppressed till patient come euthyroid, then we shift for surgery. Why? To avoid thyroid storm. If we do surgery or if we get infection, severe infection in case of patient's severe hyperthyroidism, the patient can pass to the thyroid storm, which is rare but life-threatening condition, high emergency condition, mortality 10%. Patient come heart failure, tachycardia, AF, confusion, agitation, and high fever. On treatment mainly to underlying cause in case of infection or in case of poorly controlled thyroid hormone by antibiotics, beta blocker, or dye. We give dye to inhibit the secretion of the hormone of the T4, and steroid have been used in case of to control the sign of inflammation, and also Idaron, and give oral antithyroid in case of patient conscious. If unconscious, we can do endotube and giving the carbamazole injection, induction or infusion in the endotube, because there is no parenteral carbamazole till now. And after 10 to 14 days, the patient can maintain on the carbamazole only alone and control his condition. Till now, we finished the first part of our lecture, and thank you for the listening, and good night.